Welcome to the Digital Healthcare Experience, brought to you by Taylor Healthcare.
Hello and welcome to the Digital Healthcare Experience podcast presented by Taylor Healthcare. I'm your host, Chris Civitarice, and today I'm joined by Dr. Robert Pearl, past CEO of the Permanente Medical Group from 1999 to 2017, where he led 12,000 physicians, 42,000 staff, and was responsible for the nationally recognized medical care of over 5 million Kaiser Permanente members. Dr. Pearl was named one of modern healthcare's 50 most influential physician leaders, serves as a clinical professor of plastic surgery at Stanford University School of Medicine, and is on the faculty of the Stanford Graduate School of Business. He hosts the popular podcast, Fixing Healthcare and Medicine, The Truth, publishes a newsletter called Monthly Musings on American Healthcare, and is a regular contributor to many popular media outlets. He is the author of 3 books, the newest of which, titled ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine, debuted at number 1 on Amazon's new bestseller list. And something that I found really wonderful and interesting, all profits from this book go directly to Doctors Without Borders. Welcome, Dr. Pearl. We are really thrilled to have you on the show today.
My privilege and pleasure to be with you today. Looking forward to our conversation.
Outstanding. So I'm curious, obviously you are into virtually every single aspect of healthcare that one can be into. I am wondering what led you to write your new book, ChatGPT MD. And even more so, obviously, your first 2 books straddled some really important, questions and conversations in medicine and healthcare for both patients and providers. Give us some context as well in terms of where this fits with that larger picture, if you can.
Well, I think all 3 books tie together. As you say, I was the CEO in Kaiser Permanente, and I could see the tremendous success that we were having in quality and access and cost, and wanted to see that happen across the entire United States, where it would save hundreds of thousands of lives a year, as well as maybe reduce costs by as much as $1 trillion. So there were a lot of opportunities. And when I looked at the problem, I said, we got a broken system. And that led to mistreated. While we think we're getting good healthcare, we're usually wrong. It begins with the story of my dad's premature death from a preventable medical error. And it highlights the fact that our American healthcare system is a 19th century cottage industry. It's fragmented with doctors and hospitals scattered across the community, unconnected with each other. It's paid on a piecemeal basis. We call it fee-for-service. The more you do, the more you get paid. Whether it's any good, doesn't make any difference at all. We use technology left over from the last century, although really from the one before, because the most common way doctors exchange information is the fax machine, an 1834 invention. And there isn't any leader capable of making the change happen. And I wrote the book, and a little naive at the time, I thought change would happen. And 3 years later, nothing was different. And as a professor at the Stanford Business School and medical school, I asked myself always why? Why, when there's logical things that should happen and things don't happen, there has to be a reason. So I concluded, well, it must be the culture. And I researched that in great detail and wrote the second book on caring, how the culture of medicine kills doctors and patients. I thought I highlighted a lot of ways in which our culture was left over from the last century, the things we learned in medical school and residency, and carry with us across our entire career. And again, little change happened. And I thought about it some more. And I said, the key movement, I think, is this fee-for-service decapitation. And that involves risk. And that we didn't have a tool. And I spoke with the leaders from Apple and from other companies, and I said to them, why don't you guys embed AI intelligence inside the devices that we have so we could guarantee that the outcomes might be better? And they didn't want to do it. The risks and the liability would just seem too great for a big company like that. And lo and behold, along comes generative AI. I said, now we finally have this tool that can save hundreds of thousands of lives, that can lower costs, that can reduce inequities in our healthcare system, that can reduce burnout. And I decided to write the book. And as you know, it's co-authored by ChatGPT. And I did that because I realized that unlike my first 2 books, that between writing it and editing it and printing and distributing takes 2 years in the traditional process. We couldn't wait 2 years. This technology was moving just too fast. And so if I waited more than 6 months, everything I wrote would be outdated. So that was the origin of the book and how ChatGPT became a co-author. And as you say, I'm really pleased with the fact that it is number one on Amazon's best new book list, and all profits to Doctors Without Borders.
It's tremendous. And I really, so as we were talking kind of, quote unquote backstage, I'm a big fan of the book. I love the stories that you tell to sort of illustrate the points that you're making in the book. And right at the outset, there was this wonderful sort of relation to transplant surgery and sort of what it meant for the industry and sort of how it went from something that was really obviously in infancy and just sort of, part of the contemplation of what is possible to saving, untold numbers of lives. I'm curious, do you see some parallels there? And I know you do from the book, but could you talk to the audience a little bit about some of the parallels that you're seeing where we are today in terms of generative AI and the possibilities in terms of how we can save lives with this technology and some specific scenarios where you think it can make a critical difference?
Yeah, I opened the book with the story of the first heart transplant and point out that when we think about miracles in medicine, what we think about are interventions, a surgical procedure, maybe a medication, a way in which lives can be saved that otherwise would be lost. The whole advent of oncology, chemotherapy is a great example where a diagnosis of leukemia in a child was seen as a death sentence, and pretty soon, with the work of some great leaders, we were able to achieve life-saving approaches. And in the book, I talk about this as the era of healthcare 1.0, a great era when we saw medicine go from being something that had few tools and not a whole lot of understanding to the 21st century, where we had the opportunity to be able to make a huge change. And then I point out in healthcare 2.0 and 3.0, the electronic health record and the availability of ways to provide care through the internet, that we dropped the ball. We didn't make the advances that were necessary. And today, neither of those is adding tremendous value. And so I look to 4.0, which is the generative AI. And I want to put that context of the heart transplant, not as a technology, but as a miracle. We have 400,000 patients who die every year from misdiagnoses, another 400,000 on top of that who have permanent disability as a consequence of a misdiagnosis. The New England Journal of Medicine had an article that 1 in 4 patients who either die in a hospital or get transferred to an ICU for care have a major misdiagnosis that happened around that. We know that half of Americans can't afford medicine right now. And to me, we can talk about this in some greater detail. When we look at the area of chronic disease, and I think it's chronic disease that right now is accounting both for a lot of the medical expenses. We know it's 60% of Americans have at least one, 75% of Medicare patients have at least two. We know that it accounts for 70 to 90% of medical costs. And we know that it's a tremendous epidemic. And yet we do a poor job at managing chronic disease. We know that hypertension, the leading cause of strokes, and a major contributor to kidney failure. We control it 55 to 60% of the time. It should be over 90. We did that in Kaiser Permanente when I was CEO, but it took a lot of resources and people to do it. Generative AI will facilitate that. We know that diabetes, 1 in 3 Americans have diabetes, and yet we control it only 30% of the time. This is not an opportunity. This is a tremendous opportunity. It's not something that we can accept going forward with the diabetes, major contributor to the number one contributor to kidney failure, major contributor to heart disease, 80% of peripheral amputations. And we go down all the problems that were there. And the CDC did an interesting study. They asked the following question. They said, what would happen if we could manage chronic disease as well as we are capable of? Not to eliminate it, not manage it perfectly, but simply do the things that we know that we can do, like control hypertension 90%. Is a great example of that. And they said if we did that, we would lower heart attacks, strokes, kidney failure, cancer, and peripheral amputations on average by 30 to 50%. I want people to think about that. What would that mean for the health of our nation? What would that mean for our longevity? What would that mean for healthcare costs? Talk about miracles. That is the modern miracle. It is not necessarily what we do with our hands or our ears or our eyes. It is what we can now do when we put together, and this is my perspective, the triad. Skilled, dedicated clinicians with empowered patients, and with technology. And I'm absolutely convinced that the three together will accomplish things that no one of the three could accomplish alone. And to me, that is a miracle.
I mean, that's incredibly well said. And I think about some of the sort of points that you touched on there. You talk about, the fact that healthcare has sort of gone through this evolution. We've had, EHRs, we're collecting, massive amounts of data, but everything still feels sort of siloed. I'm wondering, where do you see AI fitting into helping bridge kind of those gaps between those different sort of facets and silos that you talk about?
Well, let's look at chronic disease. And how do we manage chronic disease in the U.S. today? We manage it like it's an acute disease. I see you in the office and I see you back in 4 months. What happens in between? What we know is that there are monitors, wearable devices. My colleagues at the Stanford Engineering School produce these all the time. They're remarkable. They can measure with 99 plus accuracy blood pressure, pulse, blood oxygen, blood glucose, temperature, all the physiologic functions, the cardiac rhythms. And I defy you to find a place where these wearable devices are being used in any kind of form of care delivery. And why is that? Again, I ask that question why. Whenever I face something that makes no sense. Here we have 100%, I'll say 99+% reliable technology, and we don't use it at all for chronic disease, the number one cause of both loss of life and cost in the United States today. And it's because no one really wants that data. That's going to sound shocking. What do you mean we don't want the data? Well, for the patient, let's take blood pressure. As we said, it's only managed 55 to 60% of the time. You see a patient, they have hypertension, you start them on a medication. A month later, and they have a wearable device at home, a month later they have 100 readings. 90 are normal, 10 are abnormal. How are they doing? Patient looks at it and says, I'm doing great, I got 90 normal ones. I'm doing terribly, I have 10 abnormal ones. They don't know what to do with it. No clinician wants to receive an email with 100 blood pressure readings on it, and they don't want it clogging up their EHR. So we ignore the technology today. Imagine a generative AI tool that could look at that and could tell the patient, based upon the expectations of the clinician. And if we had a lot of time, we could talk about how easy that would be through what's called a GPT. It's a way of saying I plug in, doesn't actually get plugged in, it's actually done off a Bluetooth monitor. But the opportunity to have that data, to look at the data, and after a month say to the patient, you're doing just like your doctor expected. Keep it up and keep your 4-month appointment. Or I'll give you more update next month, the month after. Or say, no, you're not following the course. Your blood pressure's not getting better. Why would we wait 3 more months? And then 3 more months, you come to the doctor's office, they take a blood pressure, it's elevated. They say, it's the white coat syndrome or something like that. We don't have an effective way to approach it. This tool is perfect for that. It can look at the blood sugar readings. You don't have to wait 3 months for hemoglobin A1C. We can look at blood glucose readings multiple times a day, and it can do the calculation. It's a very simple thing for a generative AI tool to do. And now you have an empowered patient. As a clinician, you want to know when you can change a medication to improve an outcome, particularly when you don't really have to see the person. You know exactly what to do. And you're able to accomplish that at 1 month. And by the way, at 4 months, you don't have to see the patient if they're not having a problem. And that to me is this is the big opportunity that we have. And I just talk about chronic disease. You can look at acute disease as well. It's 11 o'clock at night and your kid has 102.5 fever. What do you do? Do you go to the ER where you wait at least an hour surrounded by people coughing? Do you wait till the morning where you Googled it on your computer and it said maybe it could be meningitis because that is a possibility. The child will be dead by the morning. What do? You call the doctor's office, and what does the answering machine say? Go to the ER. Now, why does it say that? Because it protects the doctor. And you call the answering service. They said the doctor will call you back in the morning. But you don't want that because you want to know, will my child be alive in the morning? We don't have that ability, that opportunity for an empowered patient to make the best informed decision. And it's an advance forward. I've done a lot of podcasts since the book came out. With it, as you say, being number one, I've had a lot of invitations, as you were kind enough to extend to me. And I had a host at the end of the show said, Dr. Pearl, you're a skier, you're a doctor. My husband fell skiing 2 months ago. His arm was over his head. He slid about 100 feet down the mountain. His shoulder still really hurts him, and he can't lift his arm as well on that side as on the opposite side. What's going on? And I said, you said you don't use ChatGPT. Why don't you use the free version? Put all the facts you've just told me into the system. Provide all the information about exactly what he can and can't do with that arm compared to the other side, and just see what you get, and then give me a call back. 5 days later, I get an email. She says, thank you so much. I put the information into ChatGPT. It said he probably had a rotator cuff tear. It said he needed an MRI. And it said, and this is really key, that he should see an orthopedic surgeon because he probably needed surgery. And that's exactly what happened. Surgeon made the diagnosis, got the MRI, did the procedure, and at the end said, if you'd waited a couple of months, I probably could not have fixed it because the muscle would have contracted and I couldn't have advanced the tendon. This is what an empowered patient can do. And the kinds of things I'm talking about right now are just the start of the process. I want listeners and viewers to realize that this technology is doubling in power every year, actually probably faster than that. And that means in 5 years, it's going to be 32 times more powerful. And in 10 years, 1,000 times more. If I told you your car would be able to go as fast as an airplane in 5 years, and as a rocket ship in 10 years, you'd be saying, wow, we better do something now to be ready for this tremendous advance. And yet I think we are hesitant, although it's accelerating, but still hesitant to embrace this technology at the level that we should, not for today, but to prepare for tomorrow.
It's really interesting, and empowering patients is so core to what could be possible in this brave new world that we're entering. And you outlined some wonderful examples there. I know the book has more. I'm curious. Talk to me a little bit about sort of the other side of that table, so to speak. We've heard so much about physicians, doctors, clinicians being burnt out, overwhelmed. We know that there's an obvious shortage in terms of nurses and physicians and clinicians. Do you see a home for AI, shouldering some of this burden? How do you see that playing out?
Absolutely. If you ask clinicians about burnout, they point to factors like prior authorization, EHR. These are real problems. Don't get me wrong. But if you look at the underlying etiology, why are these problems existing today, or at least a lot of these problems today? Again, I think it's the epidemic of chronic disease. You see someone with lower right quadrant pain, you diagnose appendicitis, you take out their appendix, and you don't have to see them again. You see someone with diabetes in your office, a new patient, you now have to schedule 100 visits over the rest of their life because they're going to be seen 4 times a year forever once they have that chronic disease. And we haven't recognized, I don't think, how great that is. I looked at an interesting study from the Commonwealth Fund that looked at burnout. This is particularly in primary care across countries. These are the industrialized developed countries, the Germanys, the France, Australia, Canada, etc. And I went into that saying, I think burnout in the United States must be much higher than these other countries because, we spend twice as much as any other nation in healthcare, and yet our outcomes aren't as good. They must have a far better situation there. I was shocked. We were right in the middle of the pack. We were better than 4 nations, worse than 5 nations, right in the middle. And I said to myself, what's the common theme? Because they don't have the corporatization of medicine. They don't have the patients who are uninsured. They don't have the big out-of-pocket expenses. They don't even have the high drug prices because they negotiate the drug prices. What's the common denominator? And I concluded that it had to be the fact that we are just demanding too much of clinicians everywhere because there's proliferation of chronic diseases everywhere. And if you start with that mindset and you say, okay, the goal is going to be to diminish 20 to 30% of what doctors do in the office today, every day. Because if you did that, I think the work would become a lot easier to accomplish. I think burnout really results from the fact that we have so much to do that we have to cut corners. At the end of the day, we don't feel like we've done our job as well as we know we could have, as we wanted to. They did a study where they said if primary care clinicians did everything that was recommended of them, it would take 27 hours a day. Not possible. So this is the question that I ask myself is how do we diminish by 20 to 30%? We're not going to train 20 to 30% more doctors and nurses. We also probably couldn't afford it if we were to do it. But we could transfer 20 to 30% of that work onto the patients. And by the way, if we reduce by 30 to 50% heart attacks, strokes, cancer, kidney failure, peripheral amputations, imagine how much less work we would have. But that leads to the next point. And I emphasize this in the book. If you look at technology and the adoption of technology, and you say, why do we embrace some things and we don't embrace others? It's a complex area, but it can be boiled down to two things. Anything that slows doctors down or anything that undermines their income isn't going to be adopted. So now we have the fundamental challenge that I see in the full use of generative AI, which is going to be, can we use this tool to diminish the demands on the clinician? By the way, to free up time to improve the doctor-patient relationship. I think it'll be better, not worse, if we can use the technology well, while not compromising the income. And there, I think the only way we can accomplish that is to move from fee-for-service to capitation, prepayment, pay for value. We can call it what we want it to be, but if we're able to do is to reduce all those factors, we can't then cut the income of doctors as a consequence of that. We have to reward them for preserving that health of the patient. That's what we need. How do you solve in a value-based world the challenge of cost? You don't solve it by cutting back on care. You solve it by improving health. You solve it by preventing disease, better managing chronic disease to avoid the complications, the heart attacks, and the strokes, and the cancers, right? You do it in a way to avoid redundancy of care. You empower patients so you can intervene sooner. You avoid medical errors and misdiagnoses. And this technology can accomplish all of that if we can align the doctor, the patient, and the tool together to do it. But it's not going to happen unless we move the reimbursement methodology. And if I have one concern about generative AI, it's that we are not going to be willing to do that until it is too late. Because if it's not led by clinicians, not led from inside the medical profession, I think that it will not be done in the ways that either benefit the patient adequately or the profession and the professionals who provide that care.
That's really interesting. And I mean, you're talking about, I think, sort of, elements of, our federal government. You're talking about elements of, the payer space, I would imagine, needing to be active participants in this. How do you get everybody on the same page? And where do you think that tipping point resides in terms of, physicians and sort of the medical community's feelings on this technology? How do you get those traditionally really hard to move elements of the healthcare ecosystem to move?
I think it's going to have to be led by clinicians, because you can't be able to make these changes happen unless you're able to provide an integrated care delivery system, unless you're able to bring together specialists and primary care physicians into medical groups. And so I think, and coordinate that with hospitals. And I think that needs to happen under clinician leadership. Now, the reason why I'm optimistic that it may happen is that things are getting so bad. The problems are growing.
Yeah.
And, the federal government came up with a projection that healthcare costs are going to rise $3 trillion over the next 7 years, by 2031. I don't see that as being possible. I think what we're going to see, we're already seeing, is going to be added pressure on clinicians to see more patients per day and to earn less with each. We saw for the first time, actually, in history, Medicare reduced the reimbursement to clinicians and Congress not overturning it. And I think it's the start of a change that's going to happen. And so I'm hoping that at some point, clinicians will become so, I'll say, frustrated and fearful that they actually will be willing to make the changes, to come together as a group, to be able to create a leadership structure, and be able to be led by that leadership structure in a way that coordinates care and leads to collaboration across clinicians. I had a chance to speak last week at an entrepreneurial conference in New York City. And they asked me exactly this question. And I said, in the room was the Orlando Health System. I said, I don't know anyone from the Orlando Health System, but I do know that Orlando is where Disney is. And I could imagine that if Disney were willing to say to Orlando, look, we will give you all of our employees. We're talking about 100 or 200,000 people, large numbers of individuals. And we will put them all into a capitated program. And we will pay you exactly what we paid you this year. But if you can lower the heart attacks, the strokes, the cancers, and the other things that exist, and avoid the misdiagnosis and the medical errors, and you're able to lower your costs, you'll come out really well in the end. I think that would be a proposition I would take in a heartbeat. I'd be happy to lead that group because I'd be absolutely confident that I could reduce the amount of work we'd have to do every day by 10 or 20 or 30% and increase the income by 10 or 20% on the other side. And patients would benefit and payers would benefit. So there's a win-win-win out there, but it's going to take courage and leadership to accomplish it. And that has always been the issue. And now with generative AI, I'm hoping we have the tool. I know we have the tool. I'm hoping we'll use the tool to accomplish that.
And there are some big concerns out there, obviously, about AI, and certainly some of the barriers that you described are out there and need to be overcome. But when I think about and this spans kind of the entirety of the ecosystem, patients, providers, the payer universe, the federal government, private employers, there seems to be. And maybe we're getting better, but certainly still some concerns around privacy, misinformation, bias, sort of all of the inherent ethical and sort of unknowns about the technology. How do we address this? And how do we do this in such a way that fosters and improves, patient safety, trust, and not degrade it, frankly, as the technology becomes more adopted?
As you know, the book has 5 parts to it. The first 3 are about the technology itself, as differentiating generative AI from the other kinds of AI, narrow AI and rule-based AI. The 5th part is about the role of leadership, or the role that leadership has to play. But the 4th part is about all these problems. And they have to be thought about and addressed. The biggest one, I think, today is hallucinations. But between the first version and the second version, we were able to diminish that by 80%. We know that OpenAI, and by the way, I use ChatGPT MD and OpenAI just because ChatGPT and MD flow together so well. But it's all the generative AI tools. It's Gemini from Google. It's Claude from Anthropic. So this is not specific to any one organization. I have no financial arrangements with anyone. I just use that, as I say, as a shorthand way to think about it. But between the first and second versions, it reduced hallucinations by 80%. We know that OpenAI is working on the next GPT-5, and also I'm going to assume we'll have a great diminution in that. So hallucinations, I think, are one of the biggest problems that exist. But remember, as we said earlier, doctors make mistakes. We have, I'll call them our own hallucinations. Daniel Kahneman, as Nobel Prize winners, talked about these cognitive biases that make us see things that don't actually exist. So we shouldn't assume that it is so different than that which happens to us. The challenge is, I think, that we want to eliminate it both from humans and from the technology that currently is there. But I think the technology people who are working on this, they recognize it. And I'm optimistic that, as we said, it doubles every year and 30 times more powerful by 5 years from now. It'll be better. But the other ones, I'd say we need to compare to what exists today. Don't compare to some perfect realm out there. Will privacy be worse? Well, I think when you click on Google, and I use Google's any search engine, and it's an advertising-based model, the likelihood is that privacy will be compromised more often than it will be in a subscription-based model, which is what at least the generative AI tools are today. I'm actually quite optimistic. The announcement last week by Apple that would be embedding OpenAI inside its Siri tool. And we know that Apple is going to be very focused on preserving the privacy and the security of individuals. So I think we're going to be moving in that direction. But when I compare all these different parts, even bias, what we know is that clinicians practice in a biased way. During the pandemic, when there was a shortage of COVID testing kits, we tested white patients twice as often as black patients with the same symptoms, despite the fact that mortality amongst black patients was twice as high. We know that we prescribe 30% less pain medication. We offer reconstruction after mastectomy less often. We offer advanced cardiac procedures on average we spend $1,800 a year less for Black patients than white patients with exactly the same medical problems. So that bias is built into medical practice. It then becomes duplicated by many AI tools. But generative AI has the possibility of embedding within it the notion, saying to the application, I want you to give me answers that would be unbiased. I want you to give me answers that would be including all of the literature on bias and finding ways to minimize it. So those are the opportunities I think that exists within the tool itself to be less so. Misinformation is another example. We know that misinformation is all over the internet today. We know this all over social media today. But again, I think that the generative AI tool is going to be better able and better capable than what currently exists. So when I put it into context, this is the challenge that we have in a connected era, in a computerized world, in a social media world. And I have optimism, and I write about it in the book, not that we're going to eliminate these problems. They certainly will be no worse than today, and I'm optimistic that it could be improved because of the generative AI tool being aware of it, unlike a search engine that is not.
Yeah, I think that's a great parallel too to as I think about previous technologies that have been, the last revolution, right? Whether it's the smartphone or the internet or, the PC, kind of take your pick. It seems as though as consumers get more comfortable with it, and as you say, as we use this inside of our Amazon and Google and Apple and, Microsoft platforms, that people are going to sort of naturally get more comfortable with it over time. So it feel, I would share that optimism, I guess, in terms of the way that consumers are going to look at it, in terms of the way that providers are going to look at it, and just the way that it seems to be, pervasive across all of those different pieces and parts of our society. I think that's a net positive at the end of the day.
I would agree.
So, Dr. Pearl, as we wrap up, what are you kind of most excited about as we look into the windshield? We know that people have been working on AI for a long time. It's just now sort of hitting, I'll say, the collective consciousness of people who might not have been in that space 18 months ago or 24 months ago. So as you think about what's in the windshield and what we're going to be experiencing over the next 3 to 5 years in healthcare, where do you see the growth potential with Gen AI going?
The most important part, I think, is that we recognize this exponential growth. Our minds don't do a good job of recognizing exponential growth. If you think about a pond with a lily plant on it that replicates every night, and it takes 50 days to completely cover the pond, we look and say, on day 43, only 1% of the pond's covered. This isn't a problem. Dr. Pearl, what are you talking about? Why are you telling us this thing about the lily pond covering our lily plants covering our pond? Even by day 48, it's only 25% covered. Day 49, it's only half covered. By day 50, it's fully covered. So, I'm hoping that, and why I wrote the book, is to open people's eyes to see what is coming in the future, not to focus on the past or even the present, not that we shouldn't look at the limitations. We can't miss the opportunity in looking at the limitations. And that's, I think, where my fear is. The big opportunity is it will change medicine. If we embrace it, if we can control chronic disease, better manage chronic disease, avoid its complications, if we can eliminate the medical misdiagnosis, let's say half of the time, save 200,000 lives, eliminate half of the medical errors, the preventable medical errors, the one that killed my dad, that would save another 125,000 people. Better manage diabetes and hypertension, asthma, be able to manage heart failure better. We could save another 100,000, 200,000. There's 500,000 lives that could be saved, not by raising the cost and making it unaffordable, but making it actually lower cost. Not by delaying care, reducing care, but making it easier to access by empowering patients. We're looking at a new world, a vista that's opening up in front of us. I think this is going to be the most radical change in American medicine, maybe in all of history. And it's going to happen very fast. And I want to make sure that we, the clinicians, lead this process going forward. But I also want to caution us that if we are not willing to have courage, if we're not willing to take risk, if we're not willing to lead the way, that someone else will. And once they do that, we'll never regain that control. It's why I subtitled the book, How AI-Empowered Patients and Doctors Can Take Back Control of Medicine. We've lost it. And now we have the chance to regain it. This technology has opened that door for us. For listeners and viewers who want more information, they go to my website, robertpearlmd.com, where I have information on it. I'd love to know their thoughts. I encourage them to experiment with the technology to get ahead of the curve. And as I say, in an exponential world, that curve is going to move very, very fast. But if we're able to seize the day, to take the lead, I believe that we can, once again, make American medicine the best in the world, and in the process, save the lives of hundreds of thousands of people and make healthcare affordable for our nation. I think it is an opportunity that we've all sought. We all went to medical school and went to nursing school because we were mission-driven, purpose-driven, and now we have the opportunity to transfer, to make that emotion, to make that motivation be the source of success for both our patients and ourselves.
I think that's the perfect place to leave this conversation, Dr. Pearl. I thank you so much for joining us today and sharing your insights. I thank you for the work that you continue to do on behalf of providers, patients, the healthcare industry and ecosystem as a whole. Your voice is one that is very, very much appreciated, and it was wonderful to have you on today.
Thank you so much for having me, and thank you for the great work you do helping to educate both clinicians and patients about what is possible in medical care.
Appreciate that. And thank you also to our listeners. If you enjoyed the conversation, please like, share, and subscribe to help us keep growing the show. And if you'd like to learn more about Taylor Healthcare and the digital healthcare experience, you can go to taylor.com/digital-healthcare. That's it for today. And until next time, this is Chris Civitarice wishing you health and good cheer. Take care.
To learn more about Taylor Healthcare, please visit taylor.com/digital-healthcare. This podcast is for educational purposes only and is provided with the understanding that it does not constitute medical, legal, or financial advice or services. The Digital Healthcare Experience is produced by Naomi Schwimmer, podcast music by Nicholas Bach.